Good afternoon, everyone. I am excited to introduce Dr. Singh for this session this afternoon. Dr. Singh is a board-certified child, adolescent, and adult psychiatrist who currently serves as the Vice Chair of Ambulatory Psychiatry Services at Maimonides Medical Center in Brooklyn, New York. Dr. Singh has developed a strong interest and expertise in the management of Prader Willi syndrome. He has produced numerous peer-reviewed publications and presentations, and he remains active clinically in conducting meaningful research. Dr. Singh's most recent research is examining the benefits of Guanfacine extended release with reducing behavioral problems in PWS. I know we are all very excited about this topic of behavior in PWS and are happy to have you here with us today. Dr. Singh, I will turn it over to you.
Thank you so much, Paige. This is thank you so much for having me. This is my second talk in the convention, and I've tried to make some changes, have some changes between the two. I'm going to share my screen now. Let's see if this works well. All right. I hope everyone is able to see my screen. If there are any problems, I'm sure someone will let me know. Okay, so. I'm happy to I'm really proud of the fact that the convention this time had so many presentations on behavioral problems in Prader Willi syndrome. As we saw with the data presented from the naturalistic natural history study yesterday from FPWR, a lot of our patients, in fact, most of our patients. Close to 64% of our patients, by the time that they're adults, are going to be on one or more psychotropic medications, right? And many of them are not being prescribed by a psychiatrist, and most of them are not being prescribed by anybody who has an expertise in Prader Willi syndrome. So this work is really important that the association is doing today, because I'm hoping that a lot of people hearing are caregivers and practitioners who are seeing and taking care of patients with PWS. Like Mr. Vard mentioned, I am currently at Maimonides Medical Center. It's a great place to work in Brooklyn. I'm just making a quick pitch for those of you who are interested. We are hoping to make a Prader Willi center and I know it takes time, but in the near future, we should have a Prader Willi center there. We are starting with research programming first, and we are well equipped to accept research programs to begin with, and then clinical work will start with PWS as well outside of research. I continue to do a lot of my work. My private practice is completely Prader Willi syndrome, which I'll that those of you who are interested, I'll provide that information later on. Okay, so quick disclosures. I do have a grant from the Foundation for Prader Willi Research, and I have done some consultation work for Celino, and I'm on the scientific review boards for both PWSA USA and FPWR. I do want to mention that a lot of non-FDA indicated uses of medications will be discussed, because PWS is so rare that medicines which are used in other populations or in the general population have to be used in PWS when it comes to psychiatric treatment. And I'm going to discuss that. Okay, so what are the objectives today? We want to recognize the different types of behavioral problems that can present in PWS, explain some differences between things like compulsivity, impulsivity, and then give you a concept of what's called response perseveration, and then list some of the commonly used treatment strategies. I do want to tell you. I also mentioned that I'm going to focus more on when we come to treatment, I'll focus more on the psychopharmacology, the medication aspect of treatment, because you've already heard from other speakers on the behavioral management like ABA. We had an excellent talk on ABA today. So I'm going to focus more on the medication aspects. So before we begin, this is a live and recorded session, so I'm going to be nice on camera. I have virtual background, so if a part of me goes missing, that's just a glitch that's not coming from me. We want to have an active chat, but please pose your Q&As and we'll get to them towards the end of the session. And it will be impossible to cover it all because it's such an extensive topic, but I'll try my best. If anyone wants references or they heard something new here and want to hear about where I got that information from, feel free to email me and I'll send it to you. Okay, so I want to start with the non-expert in PWS. Most of you are living in regions, or most of you don't have access to experts in the field. And this is an example of what would be a question in the USMLEs, which is the medical licensure examination, sort of like board exams, so to speak, for all medical providers or physicians. And I want to highlight this because this is basically the image of a person with PWS that all physicians have, right? And most physicians will spend their lifetimes perhaps seeing one or two patients with PWS, and that's that. So you can't blame them from having only this image. So let's look at this description. This is a 12-year-old male who presents to the peds clinic. He's 4 feet 2 inches tall with a weight of 151 pounds. On exam, he was noted to have small feet and hands. Parents report that he was born hypotonic. Over the past 3 years, he's described as having insatiable hunger to the point that he has been found to eat out of the garbage can when others aren't looking, and is continually preoccupied with food. His parents describe that he has been getting more aggressive lately, especially when asked to stop eating. What is the most likely finding on genetic testing? This is a classic exam that all medical students are preparing for. Basically, all they need to know is that patients with PWS are overweight, they have small hands and feet, they may be hypotonic, they have hyperphagia, and they can get aggressive, and that there's a genetic abnormality. That's it. Most of the parents on this call or who are viewing this video know at least 10 things more than what's listed on this. So it's no surprise that parents come to me very frustrated with the way they might have been treated, or or frustrated with the fact that they have to do a lot of education and advocacy when they're taking their child to a medical provider. So, quick introduction that you are already familiar with: the three mechanisms, genetic mechanisms behind PWS. The most common forms would be deletion. There are two types of deletion. Then the second most common would be uniparental disomy, and then the least common would be the imprinting effect, which is the methylation defect. There are differences between uniparental disomy versus deletion, but in my experience, one can't assume that to be the case always. You can't predict that a person with UPD, for example, will always have a psychotic break, or a person with deletion would not. So that's these differences are important statistically speaking, but clinically speaking, you have to individualize the care based on how the patient is presenting. So today in this talk, we won't talk about the genetics behind the stuff, because that people already know. And we're going to talk about the behavioral aspects, because there are not enough psychiatric services available. I can count on two hands the number of psychiatrists who have an expertise in PWS, maybe even one hand, in the world, not just the US. And that's a problem. It shouldn't be that way. Basic principles of management can help. So even the experts in PWS who are non-psychiatrists, just having that basic information, or having a buddy that they can go to just run a question by, a friend in psychiatry, can be very helpful to manage patients who don't have access to a psychiatrist themselves. And it's important to work with the patients and families to draw a timeline. And we'll talk about this quite a bit. It's important to make a differentiate between what we call is the baseline and what's new, right? So patients with PWS might have some chronic issues, right? So they might have repetitive questioning as a behavior. They might have interest preoccupation, the same things that they're interested in all the time. But that's like constant, right? Or they might have some inattention or hyperactivity, but that's constantly there. What becomes important to point out is what was always there and what has occurred all of a sudden. What's new for the patient? Now, a quick, but important message to not go this alone, right? This is taking care of a person with Prader Willi syndrome is not a flight for Superman or a super person. You cannot do this alone, and study after study has proven that caregiver burden is a big issue. And it can affect the caregiver's emotional well-being, social well-being, financial well-being, physical well-being, and spiritual functioning. And bottom line, it can really, it is very important to address that workload imbalance. Ask for help. Ask for help from school. Sometimes you have to fight for help from school. Ask for help from family, and these gender roles of what does the father do and what does the mother do and all of that. And, depending on the culture that you come from, we need to break those barriers and really ask for help, because doing this alone can really, take a huge toll. I've had patients, parents who have come to me like suicidal because of severe depression. I've had to send them for treatment. So it's important to address your own well-being. So let's start with acknowledging the struggles and the suffering of the caregiver, the self-sacrificing parent, the idealistic clinician, or the young trainee who wants to treat patients with PWS, and address your stresses so that you can take care of others. So there's a huge range of symptoms, neurobehavioral symptoms that can affect PWS. This is in no particular order. Obviously, the most common one that people associate with PWS is hyperphagia and perhaps aggression. And then, there's also intellectual disability, and which can be very deceptive. The parents are always surprised that, okay, my child is so good with expressing themselves, or they can sort of like tell me the whole story of what happened in the movie that they saw this morning. But when it comes to simple tasks like, tying the shoelaces or doing, what requires some executive functioning, like perhaps a math problem, a simple math problem, they're not able to do that. So that discrepancy between their language development and the rest of their intellectual functioning can sometimes be very problematic. So it's important to look at not the chronological age. So if a child is 15 years old, right? Their chronological age is 15, but their developmental age might be 6, right? So if they're throwing a tantrum, and they were so well versed with they're so expressive, but they're throwing a tantrum like a 6-year-old, you need to remind yourself that they're not 15 right now. They're 6 in the way that they're behaving, and that's how they need to be handled. Autism is underdiagnosed, undertreated in Prader-Willi syndrome, and there were other talks in the convention addressing how to treat ASD and how to advocate for your child and get them the diagnosis that they need, because some clinicians who are unaware will say, oh, no, everything is PWS, we can't call it autism if they already have PWS, and that's a problem. The obsessive compulsive symptoms associated with PWS are not the same as OCD. We'll talk a bit more about that. ADHD is very common in PWS. ADHD is very common in any patient with a neurodevelopmental disorder. But in particular with PWS, that becomes even more common. Now, perhaps because of the low muscle tone, hyperactivity in their movement is not really, not present always. So it can be deceptive, because you'll say, oh, there's no way my child has ADHD because they have excessive daytime sleepiness, and if anything, I would like them to be more active. But then, so it's not just the hyperactivity when we are talking about ADHD. The ADHD inattentive type is common in PWS. Mood disorders include depression and bipolar disorder. Bipolar disorder is less described, other than a study that I'll talk about a little later. And there seems to be a mix of mood and psychosis type symptoms that we can see in PWS. And there was a very good presentation yesterday describing what we refer to as cycloid psychosis, but there was a case of catatonia in a patient with PWS, which was described as a poster yesterday. I can tell you that there was classic cycloid psychosis, very interesting case also. So we'll talk a bit about that. Now you notice that on the map, anxiety was missing. Why? Why is that? Why is anxiety missing? That's because the anxiety disorders that we have in the DSM, say, which is the diagnostic Bible that psychiatrists use to diagnose things, it has conditions, very well described anxiety disorders, but PWS does not seem to, our patients, our loved ones, don't seem to have the exact same symptoms. So let's go into that a little bit. What do we know about anxiety disorders? First of all, anxiety disorders or anxiousness, the feeling of anxiousness, the symptom of being anxious is a feeling. It's a feeling state. Everybody feels anxious. If I was in front of 1,000 people right now instead of speaking to a camera, I might be more anxious than I am right now. That's normal. That's anxiousness, the feeling. And that is what people come to me with. So a parent would come in and say, my child is really, really anxious. And the first thing I tell myself that it's not that the parent is saying that the child has an anxiety disorder. They're saying they're showing symptoms of anxiousness. Now, anxiousness can become a disorder, which is one of the more common ones would be generalized anxiety disorder, or GAD, in which there's a free-floating anxiety about anything and everything. Did I do my dishes? Did I finish my work on time? And there's been quite a few. There was a comment that the sound was not loud enough, so hopefully this will work. I just raised the volume. Okay, so in generalized anxiety disorder, there's this free-floating anxiety that doesn't fit the bill with patients with PWS, because PWS, it's not like they're anxious about anything and everything. They might be anxious about food. They might be anxious about, when am I going to go to see Dr. Singh, or they might be anxious about, when their next play date is going to be. But that's not a constant state of anxiety that we see in patients with GAD without PWS. Specific phobia would be things like hemophobia, which is a fear of blood, or arachnophobia, which is a fear of spiders, or a fear of, say, heights, which is acrophobia. Those are specific phobias. These are very common in the general population. I don't see, specific phobias per se in PWS as common either. Separation anxiety is important to know about, because I do see it in patients with PWS, and especially around COVID. It has become more prominent because there are kids with PWS who have lost their grandparents or parents, and there's this heightened sense of anxiety about their own lives or the lives of others. Now, it's very important to understand that every child is different. Every child with PWS is also different. So, one needs to understand what their understanding of death is, right? So for example, in the general population, the understanding that death is permanent comes around 6 years of age, right? But in PWS, I've had patients who are in their 30s who will sometimes ask for their grandparents who passed away by COVID over the past year. And they're asking to see where they are, despite being told that they've passed away. So separation anxiety and grief might look very different in patients with PWS. So how does separation anxiety present itself? There are people who will be concerned, the patients might be concerned that they are, that something bad will happen to them or to their loved ones, their parents, their grandparents, an attachment figure. It could be a caregiver, a healthcare worker that they're close to, and they have trouble separating from them because they're afraid that something bad will happen either to them, to the patient, or to the attachment figure or the loved one. And it can present with headaches, bellyache, problems with sleep, and also in PWS in particular, because they may not be able to call it a fear of separating. They may not be able to say that I'm afraid something bad will happen if you're away from me. It might present as agitation and aggression, especially when you're trying to go back to school post-pandemic. They'll refuse to go, or they might throw a tantrum, or they might get aggressive. Social anxiety, not common PWS. Kids and adults with PWS like to be around others. They're not very isolatory, unless that's part of their autism comorbidity. So as we discussed, the core anxiety that we see in PWS does not really fit the bill with any of these, right? Although they might have comorbid, they might also have separation anxiety. The core features that people call anxiety is not described in the DSM. Now let's come to OCD and related disorders. So there's the disorder obsessive compulsive disorder. Now parents would often come to me and say that, okay, they're convinced that their child has OCD. Now that might be the case in a few of them, but for most of them, they're obsessive about something or the other. It may be food, but it may also be non-food related. They might be obsessive about their DVDs, or they might be obsessive about, how their parents are sort of like going about getting them ready for school in the morning, right? And they might be compulsive in the sense that they might ask you to do the same thing over and over. They might do the same things over and over. But then it's not OCD, because these obsessions and these compulsions, first of all, they're not ego dystonic. They're not bothered by it. They don't see them as problematic. And they're pretty much, constant. They don't change. So in classic OCD, in other folks without PWS, they won't have that. And this is actually the perseverative behaviors and the interest preoccupation that you see in PWS is somewhat closer to the way we understand it and see it in someone with, say, autism than with someone with OCD proper. Body dysmorphic disorder, which is a discomfort and a pathological discomfort with a part of their body, is not something that I see very often, but it can happen. I had a patient who would be preoccupied with a part of their body and would touch it constantly, or complain that they need to change it, or they want to do a surgery to make it smaller or bigger depending on the body part, but very rare and not like common as like, I won't call it like a PWS related anxiety. Hoarding, on the other hand, is highly common in PWS. So common, in fact, that the DSM, our diagnostic manual has called PWS an exclusionary diagnosis, in the sense that we can't diagnose a person with PWS as having hoarding disorder because of how common it is. So common that it should be considered part of the syndrome itself. Okay, but it is common. And you name it, they hoard it, right? Whatever. So I've had patients who hoard keys, strings, coins, and stationery by far is extremely common. So those of you listening, they'll identify it as, okay, yeah, so I see that all the time. And that can make their back and other muscular problems worse, because they'll have like these heavy bags that they carry everything in, and that might worsen their scoliosis as well. Skin picking or rectal picking, and picking of any sort, right? It's called excoriation disorder, very common in PWS, and it can be really bad in the sense that it can it can lead to non-healing chronic wounds that need wound treatment with sort of something like hyperbaric oxygen treatment or surgical treatment. Now, surgeries by themselves, if the surgeon is not familiar with PWS and not familiar with the fact that skin picking can be a problem, might not take some of the steps. So an example that comes to mind is a patient of mine who needed a dental, an oral surgery, and they had an implant placed, and the patient, the second they got a chance, they pulled it out, right? And this is an expensive, procedure, and once the oral surgeon understood that this patient has PWS and this might happen again, they actually did an additional procedure that removed access to the surgical location for the patient, so the patient could sort of, and then they had a better outcome. So those kinds of that kind of education and making sure that everyone is on the same page could be an important role of your child's psychiatrist or mental health provider, because they might just pick up the phone and call the surgeon and say, listen, you're going to do surgery in this patient with PWS, just so you know, this is what to expect, and try to do things to mitigate those risks and side effects. Hair pulling, not as common as skin picking. Hair pulling is also called trichotillomania. Not as common as skin picking, but still quite common. I've been surprised to see how common it is. I don't think it's as commonly described. I've had patients who've pulled their eyebrows out, eyelashes out, their hair. They have bald patches, not just from skin picking, but also from hair pulling. So again, the obsessive and compulsive symptoms in PWS, right? The repetitive behavior is not OCD in the classic way that we understand, just to summarize. So the anxiety that people come into the clinic with has to be sort of differentiated. So we have to, providers who are taking care of patients with rare diseases such as PWS, they have to really, instead of focusing on the forest, which is what we are taught to do, that first vignette, that first case example that I showed, where a physician is trained to look at a picture, make a big picture, give a diagnosis, and treat that diagnosis, doesn't work as well with PWS, because we have to actually force ourselves to look at the trees and not get lost in the forest. We have to look at the trees. Okay, they're coming in with what they're calling anxiety, or what can look like anxiety, but what is actually, when you inquire further, what is causing it? And you have to treat the underlying cause. Okay, so if there was a diagnosis that could be given, an example diagnosis in a patient with PWS would be something like obsessive compulsive and related disorder due to PWS with OCD-like symptoms, hoarding symptoms, and skin picking symptoms. It doesn't make sense, right? I mean, it's a mouthful. Again, we are trying to sort of categorize something which is uncategorizable because it's so rare. We can't write like the full DSM will never be able to help one person with PWS because they're so rare. So it needs to be individualized, that diagnosis and the care that is provided. Okay, so that brings me to response perseveration. So if it's not GAD, if it's not, classic anxiety or OCD, what is it? So let's go deeper and think about what the underlying mechanism might be. Now, all of us have the ability to respond to something negative that happens in the environment. So, as an example, if imagine a child who does not have PWS, right, and they really want a toy, right, and they've asked for it 10 times, they keep pulling at your shirt sleeve and they say, I want it, and you sort of get upset with them and say, I told you no, you're not getting it, you have to wait till Christmas. Whatever you say, they get an answer from you, and they also see that you're upset, that this is something that will lead you to get even more upset if they keep pursuing it, and they back off. They stop asking about it, right? So that would be a normal situation where people see a negative outcome and then they back off. But in PWS, it seems like that doesn't happen. They are seeing that you're upset. They're seeing that this is not a conversation that is going to end well. And you can see, and it's frustrating you that they're not getting it, that they keep coming at you, and they're intrusive, and they won't stop doing what they're doing despite the harm that it's going to cause them. This is called response perseveration, right? It's almost like it's not been described much in PWS. It's been described more in patients with addictions and patients with say things like gambling. They would keep wasting their money despite knowing that nothing's going to come out of it, right? And that's response perseveration. It seems to be a theory that would explain what's going on in PWS. How? Because it seems to be related to their compulsive behavior. So they keep engaging in that intrusive behavior, such as repetitive questioning, despite the negative response by caregivers. And it instead of making it, although they appear anxious, it's a sign of impulsivity, which is the tendency to engage in rash or ill-considered action in response to intense negative emotions. So, as an example, if you're a teacher, right, in the classroom, and a child gets upset with the grades that you gave to them, right, the child might feel like flinging a chair at you, but there's a part of them that kind of that tells them that, oh, you know what, that's not a good idea, and they're able to stop themselves, right? But on the other hand, someone with PWS, they get really, really angry in the moment. They might react in that impulsive, violent way. This is called reactive aggression. And this is very different from the malicious, sort of planned, cold aggression that people with antisocial personality or someone like Bernie Madoff might have, right? That's not what we are seeing in patients with PWS. They're not planning it, and that's why many of them will come back and say sorry. So a quick thought, related thought about confabulation. Confabulation is speaking falsehood or lying incessantly, and it seems that, and it's been described in PWS. Now, one has to think about that for a second, right? So if and again, this is my understanding of why that is common in PWS. A part of them is it's hard for them to accept that they're wrong at any point. Second, B, they might be so tired of being wrong all the time that they can't take it anymore. How many times is one person supposed to say sorry about the same thing? It's easier to say, I didn't do it. What are you talking about? I don't know how that happened. I didn't do it. So that's impulsivity. And it is associated with low volumes of prefrontal cortex. So this is the dorsolateral prefrontal cortex. This is basically the strongest part of the human brain. This is what differentiates us from other species, because we have this large front of the brain, which provides executive control to the rest of the brain. So when in that child, the lower part of the brain got hot and heated up when the teacher gave them a bad grade and they wanted to throw the chair, they had that image of throwing that chair at the teacher, but then the dorsolateral prefrontal cortex steps in and says, dude, bad idea. Step, this is not going to end well. Don't throw the chair. What happens in unfortunately with PWS is that is not functioning well, and that, so we spoke about response perseveration, right? The opposite of that is response monitoring, which is what that child did when they stopped themselves from throwing the chair. They're adapting, they're being flexible, right? And they're adapting to a situation which is changing rapidly, and they want to make sure that they don't get into trouble, and it helps them, with their functioning. Now, when there's a dysfunction of this part of the brain, it can lead to response monitoring not working as well. It can make people inflexible. It can lead to compulsivity and perseveration, right? And that has been studied in stroke victims as well. If that part of the brain is damaged, it can lead them to cause similar behaviors and make them impulsive and perseverative. So, in addition to the expected hypothalamic and pituitary problems that patients with PWS have, studies have shown that there are abnormalities in the dorsolateral prefrontal cortex, which would explain the response perseveration, the lack of response monitoring, the inflexibility, and the compulsive sort of behaviors, as well as the aggression. Now I'm going to talk about something different, right, which is cycloid psychosis. Now we're talking about a totally different ball game here, right? Cycloid psychosis, when we were talking about things which are at baseline with many patients with PWS. It doesn't appear all of a sudden. All of their lives, they might have had it at different degrees, right? Cycloid psychosis is this weird amalgamation that is seen in some patients with PWS. Actually, some studies have shown up to 60%, more than 60% of patients, especially with the UPD variant, will show psychotic symptoms at least once in their lifetime. Quick comment on what psychosis is. Psychosis is a lack of reality testing. So people have trouble telling what's real from not real. As an example, they might start hearing voices that no one else can hear. They might start believing things which are bizarre or cannot be real, right? So a patient might say, since I went to the dentist, I've been, the dentist put something in my body which is making him control my body. Bizarre, right? Not possible. At least I hope so, right? And that's a delusion. That's a type of psychosis. People talk about visual hallucinations as well, which is seeing things which are not real. Visual hallucinations are very rare in PWS or due to any psychiatric problem. So if there's a sudden onset of very florid visual hallucinations, people might say, they had a nightmare, or they might see something in the closet when it was dark, or they might misinterpret someone's look, or if someone is wearing dark glasses, they might say that, I saw someone from FBI. That's not what I'm talking about. I'm talking about seeing something which appears totally real, like a person or something else, and that's like a real fully formed visual hallucination. That if your child suddenly develops something like that, you need to take, see them and get them evaluated, not just by a psychiatrist, but also by a neurologist, because there might be something else going on, physical, that might describe it, that might be responsible. Now, cycloid psychosis, on the other hand, is this sudden onset of psychotic symptoms combined with what's called catatonic features, which was described yesterday in a talk. But basically, people might stop moving. They paradoxically stop eating or eat very less. They might appear very, very anxious. See? So anxiousness, if it occurs in a severe form and all of a sudden, it may not be just an anxiety issue. It might actually be the presentation of an underlying psychotic process. This requires a psychiatric evaluation immediately. You can't really, it's beyond the realm of, beyond the expertise of any non-psychiatrist or non-mental health provider who's familiar with psychosis. And the good thing about cycloid psychosis is that just as it comes up like as a volcano bursting, all of a sudden all of these changes come up. They become psychotic, they stop sleeping, they might have catatonia, they might have anxiety, they might be very aggressive. It responds really well to treatment with medication, and people tend to go back to their baseline very quickly. Now, so I'm going to talk about treatment in general, about a ton of different medicines, and I don't think there's enough time to cover even one of those medicines. So I'll just talk about some key features because, as we heard yesterday, about 66% of the patients are on a psychiatric medication, and many of them are on more than one. So it's important to know about them. I'm going to talk about, I'll start with benzodiazepines, which are things I'm going to talk, just mentioning brands just so that people would recognize them. Alprazolam would be something like Xanax, clonazepam is Klonopin, lorazepam is Ativan. By themselves, these are not bad medicines, and they're very helpful for anxiety when used in the short term. But in patients with PWS, because of the way their brain functions, they already have trouble breathing. So this might suppress their breathing even further. So if your loved one has really bad obstructive sleep apnea or central sleep apnea or narcolepsy, especially sleep apnea or central sleep apnea, then you might want to avoid these medicines because they will cause the apnea to worsen, right? The other problem with benzodiazepines is that it can paradoxically, right, ironically, can cause agitation. So although they're sedating agents, they might disinhibit you. Just think of, for those of you who've ever had a drink, if you have 1 or 2 drinks, it loosens you up. If you have 10, you fall asleep. So similarly with benzos, if you don't dose it right, it might actually loosen them up further and they might become aggressive and assaultive. So that's a paradoxical reaction. Now, by far in my experience, and we have to look at the data, SSRIs are very commonly prescribed in patients with PWS, which are things like sertraline, which is Zoloft, citalopram, Celexa, fluoxetine is Prozac, and there's Lexapro, which is escitalopram. Nowadays, patients are being prescribed Trintellix, vortioxetine. There are many different types of medicines, but they all do the same thing. They increase the level of serotonin in the body. Now, in patients who are at risk of developing cycloid psychosis, which most of our patients with PWS are, these medicines by themselves, especially if dosages are increased at higher levels, can precipitate a cycloid psychosis or manic episode. And that's one of the reasons I prefer not to treat patients with these medicines. Although I do have some who I've inherited from others, and if they're doing well on it at low dosages, I try not to mess with it, but very often I would discontinue it and try to use something else. Remember, these are antidepressant medicines or used for like classic anxiety disorders or classic OCD. So if you go to a general practitioner or a psychiatrist who's unfamiliar with PWS, they might diagnose their anxiousness as generalized anxiety disorder, or they might diagnose their compulsivity as OCD, and they might prescribe this medicine not knowing that it can cause psychosis or mania. So that's important to keep in mind, and you might want to educate the provider about that risk. Now, keep in mind, for any of these medicines that I'm describing, I'm focusing on the effects and side effects, but these may not apply to your child. So don't make any drastic changes in your child's medication without talking to the prescribing provider first. Antipsychotics, another commonly prescribed medication. Antipsychotic medicines are called antipsychotics, but they're not used only for psychosis. They're very effective for aggression also, right? And there are 2 different types of antipsychotics. The older ones are called typical newer ones are called atypical antipsychotics. The atypical antipsychotics in particular are used very often in PWS because they are effective for aggression, but they can cause weight gain. Most of the antipsychotics can cause weight gain. Aripiprazole in adults has been shown to be, aripiprazole is Abilify, supposed to be relatively safer for weight gain. I personally prescribe lurasidone, which is Latuda, quite commonly because it does not cause as much weight gain, but I would prescribe it only if I've exhausted other ways of treating the aggression, or if the patient has psychosis. If the patient has psychosis, you have to treat it with an antipsychotic. Now, some patients will benefit from mood stabilizers. Now, based on the research which has been done in children and adolescents for the treatment of mania and bipolar disorder, mood stabilizers are actually not as effective as antipsychotics for the treatment of mood problems in children and adolescents. So based on that evidence, I prefer to use antipsychotics for severe mood symptoms or psychosis. Mood stabilizers like lithium, I prefer to use only if there's significant risk of self-harm or suicidality, because lithium lowers the risk of suicidality. Valproic acid, which is valproate, also called Depakote, is used very commonly. Both lithium and valproic acid can have, can cause weight gain. Lithium can also mess with the thyroid function of individuals, so that needs to be looked out for. We have lamotrigine, which I use quite commonly because it's safer, but it has a very severe skin reaction in some patients. So you have to start low and go slow with lamotrigine. Topiramate, good medicine for skin picking, and well tolerated. You got to make sure that the child is well hydrated because it can cause kidney stones in some patients over a period of time. Topiramate is something that I avoid in high functioning patients with PWS who have lots of academic aspirations, because it can slow down the capacity to do sort of mathematical problems, for example. So if you have someone who's preparing to go, has aspirations to go to college or is very high functioning, then I would probably avoid topiramate. Gabapentin is, more recently I'm seeing a lot of patients on gabapentin prescribed by primary care providers, and that worries me because although it helps with anxiety, it is known to cause weight gain. I don't like using carbamazepine or oxcarbazepine because they are kind of dirty drugs and they fight with the other medicines and can lower their functioning. And they can cause sodium abnormalities, and so that it's not, in my opinion, they're better options. Bupropion and mirtazapine, again, very little evidence. Mirtazapine in particular can cause weight gain. It's called Remeron. I stay away from Remeron. I would suggest that that patients with PWS not take Remeron because of the potential of significant weight gain. Bupropion is a good that's Wellbutrin. For those who don't know, it's a very good option for some patients with PWS who don't have any psychotic symptoms. It doesn't help with anxiety, but it helps with depression, and it does reduce the appetite somewhat, and it helps with wakefulness in some of my patients. The one reason to avoid bupropion is if the child or the adult has ever had a seizure episode, I would stay away from it, because it can potentiate seizures. NAC, most of you know about it already, N-acetylcysteine, over the counter. You don't have to go all out of your way to get Pharmanac, which is the melting tablet. Any NAC from a reputable over-the-counter medicine is fine. So there's some early evidence which I'm going to skip because that's been covered in other talks during the session. My particular sort of discovery in PWS was the use of alpha-2 agonists, which are medicines like Guanfacine and clonidine in the treatment of PWS. These work by increasing the activity of the dorsolateral prefrontal cortex, and improves functioning that way. So I'm going to fly through the next few slides because I know we are almost out of time. Just a quick, reminder that Guanfacine, although I have published and we know that it is very effective, highly effective in many patients who take it for skin picking, aggression, agitation, and ADHD symptoms, it still needs to be studied more rigorously, and that's the clinical trial that I'm doing. If you're interested in the trial, feel free to call this number on the screen, or email Dr. Theresa Jacob, who is my director of research. If you have other questions, concerns, this is my direct information for my email and my phone number. Looking forward to hearing from everyone, and hopefully we have some time to answer questions. Sorry if I went over.
Thank you, Dr. Singh. Wonderful presentation, as always, full of lots of information, and we definitely have questions. So the first question is from someone who works in a group home with adults with PWS, and they would like to know, they're often struck with their lack of ability to regulate their emotions, and they're wondering if you use or recommend CBT or DBT therapy for people with PWS.
That's excellent. So that's a good question. So DBT, I would simplify it because DBT itself is a very complex sort of treatment modality and patients with PWS may not be able to respond to it. But then the crux of it is mindfulness, right? Being in the moment. And mindfulness actually has been studied in PWS and has been shown to be helpful. In particular, Nirbhay Singh, Dr. Nirbhay Singh, he has done studies on reminding the adult or someone who's aggressive, like practicing with them to focus on the way their feet feel on the ground. So it's like literally grounding themselves in the moment when they're losing their cool. The important point to remember is that you need to practice these kind of mindfulness techniques, be it breathing or focusing on a bodily function or grounding themselves. Those kind of exercises need to be done regularly, not just when they're upset, because then it won't work. If they're constantly practicing it, then in the moment, if you remind them, okay, this is the time for you to try and do that mindfulness exercise that we practice together, that might work.
Okay, thank you. Another question, you talked a lot about a lot of different medications. There's a question about what is a replacement for Lexapro?
Right. So it depends on when Lexapro, if I went to my primary care doctor, right, today, and I said that, I've been feeling sad and, I've been crying a little bit and having some trouble sleeping the past few nights, I'm going to get something like Lexapro. And I'll get like a 3-month supply with 12 refills. Okay, that's how commonly and easily prescribed Lexapro is. On the other hand, we need to look beyond what you're seeing on the surface with the patient with PWS, because it's very likely that they don't have a major depressive disorder or a major anxiety disorder like we spoke before in the talk, and the underlying cause might be impulsivity, might be ADHD, might be problems with anger or self-regulation like the previous question asked, in which case Lexapro may not have as much benefit and the risks might outweigh the benefits. And I would use an alternative, something like Guanfacine extended release, something like clonidine. I might use, if the underlying anxiety is causing aggression instead of Lexapro, I might go to an antipsychotic type medicine, which has more evidence for aggression.
Great, thank you. Another question, what is your preferred frontline treatment for anxiety symptoms in adolescents?
So adolescence, again, I think the previous answer would apply to this as well. Now, adolescents are a tough breed even in PWS. Trust me, it's not just the regular folks. The PWS adolescents are a handful as well. And that's because their brain is rapidly changing, just like all other adolescents. And it might precipitate psychosis. So if the anxiety, I don't know, what the person's particulars are, but if the anxiety is new onset, the person was never anxious before, all of a sudden they're getting anxious, they're not being able to sleep, they're having these other symptoms that can co-occur, then I would have to sort of like diagnose that differently, and I won't even call it anxiety in that case. But anxiety, the kind that we see in PWS, like I said, I usually don't use the classic anti-anxiety medicines such as SSRIs or benzodiazepines. I would use an alpha-2 agonist. I would use sometimes something like an atomoxetine, which is Strattera, or other norepinephrine reuptake inhibitors, but not a classic SSRI.
Okay, thank you. Another question, you talked a lot about the different disorders that can appear. How early can these disorders present in Prader-Willi syndrome?
Right, so ADHD is pretty much lifelong. Inattention can occur right from the time that it might be noticed in preschool. So the teachers might say they're always, this particular child is never participating in circle time, needs constant redirection. So you'll start seeing features of ADHD earlier. A little later, you might start noticing skin picking and excoriation problems, and occasionally that progresses to rectal picking. A little later, you might, especially if the child has very high intelligence or in the normal or near normal intelligence range, then they might notice their differences from others. And it's around that time that they might start expressing thoughts of depression. Why am I like this? Why am I different? Right? And then it's usually in the later adolescence period that some patients, again, I don't want to scare people, not everybody would get like a psychotic episode, but in the later adolescence period, you might get psychotic episodes. And of course, people are not like patients with, the take-home point would be that the patients with Prader-Willi syndrome have vulnerable brains, more vulnerable than ours. So instead of blaming everything on the PWS, we have to think that because their brains are more vulnerable, they're actually more likely to have neuropsychiatric conditions in addition to PWS.
Okay, we have a couple of minutes left. A question around, you've talked a little bit about skin, rectal picking. Somebody has an individual that has some issues with this and have been hospitalized. And they're taking fluoxetine, 20 milligrams right now. Is there something better than that?
Oh yeah, lots of things which are better than fluoxetine. I would say that unless there's there are very few harms to adding N-acetylcysteine, which is NAC, to the treatment, and people underdose it. So you start it at it's over the counter, 600 milligrams twice a day is pretty much the minimum starting dose, and the upper limit is very high. Of course, you need to be under the care of someone who knows this. So I won't tell you what the upper limit is, otherwise everyone will start giving it. But NAC is very helpful. Guanfacine has been studied and has been shown to be helpful. That was my study. And topiramate, which is Topamax. These three, I would say, are the most studied. Naltrexone, some patients use as well. So perhaps these four would be preferable and more studied than the fluoxetine. Fluoxetine has one study to my knowledge, but that was a very small study.
Okay, we are out of time. So I want to thank you, Dr. Singh, again for a great presentation. And thank you, everybody who joined and asked questions. And please feel free to join us at the next session. Thank you.
Thank you very much. Thank you for having me. It's been great.